So next speaker is Dr. Trupti Pai. She is working as an associate professor in pathologist as TMH Mumbai. And after doing MD in pathology, she has had a fellowship in molecular pathology. And she was also selected for one-year fellowship in translational cancer medicine from King's College London. Subsequently, since 2017, she has been working at TMC Mumbai, and her areas of interest are thoracic oncopathology and molecular pathology. She is actively involved in the validation and reporting of all solid tumor molecular assays, including NGS, and her research areas of interest include microenvironment, HER2 genomic heterogeneity, and biomarker assessment in lung. So welcome Dr. Trupti to present this talk on the latest, testing which is now included in breast cancer.
Thank you, Dr. Sunila. I will be talking on the role of genomic testing and liquid biopsies in breast cancer. So as we saw in previous talks that a detailed histological evaluation and EPC status like ERPR and HER2 status gives the management profile in majority of cases. So which are the cases where we need the genomic testing or liquid biopsies? So as we all know, this is a personalized medicine era or the era of genomics. So does that mean that every case we will ask for genomics? No. So I have taken certain clinical scenarios where the genomic testing will play an important role in management decisions. So I will be talking on some gene expression assays, certain targets like PIK3CA and BRCA, which are playing an important role in clinical decision making. And then lastly on the liquid biopsies. So first and foremost, regarding the genomic testing, for every clinical scenario, first we have to ask, is there a need for genomic expression profiling in a particular case? So this is a particular case subset, which is like early breast cancer, tumor size less than 5 centimeter, hormone positive, node negative, or maybe 0 to 3 positive nodes. So this is a subset in which there are majority of gene expression analysis, which are done to see if patient needs adjuvant chemotherapy or not. So again, as I said, there are many assays. Each patient should be considered for only one assay, and these are not like interchangeable. Again, if you think that the patient is not going to undergo further chemotherapy treatment, or if it is refusing to chemotherapy, then there is no point of doing such advanced testing, as these are very expensive testing. So first and foremost is particular clinical scenario, we have to assess what is the need for testing. So EPC has already been covered. So like the same settings of early breast cancer node negative, we have this test like Oncotype DX, Mamma Print, or PAM50, which will help in deciding or predicting recurrence or to select patient for chemotherapy. The next subset is like locally advanced or tumor that is like resistant to previous lines of chemotherapy. In such cases, you can ask for NGS targeted sequencing to see if any actionable mutations are present and treat accordingly. And then most of the cases, they have sent for germline testing, especially if young patients or in triple negative, just to identify the genetic predisposition or for counseling the patients and relatives. So these are broadly the case scenarios in breast cancers. So coming to the first scenario, like as I said, there are this gene expression testing like Mamma Print, Oncotype DX, Breast Cancer Index, PAM50. So all these target like different genes, and basically the spectrum is early breast cancer. So if the nodes are like 4 or more positive, or if it is a HER2 positive tumor, then there is no point in doing this testing. Of all these tests, like Oncotype DX is most frequently asked for. So what is this Oncotype DX? It is a 21 gene multiplex prognostic and predictive reverse transcriptase PCR assay. So what it does, it takes into account 21 genes which has this proliferation, invasion, HER2, ERPR, and some reference and other genes. And there is a particular formula for this assessing. According to this, there is a tripartite recurrence score that is generated. So if in a particular this scenario, if the patient has this high risk, then it suggests that there is definitely a benefit of adjuvant chemotherapy, and it will be worth considering patient for chemotherapy. So that was like gene expression assays. I won't go into much detail. So I just covered Oncotype DX as it is the most frequently used one. So second is the PIK3CA pathway. We now know that recently the FDA has approved this PIK3 inhibitor. So that is why I have covered this PIK3A pathway. So PIK3CA pathway is like you can have this cell membrane tyrosine kinase domain mutation, or there are some other genes in the downstream pathway. But we will be focusing on these gene mutations as the drug specifically is important when it has a PIK3CA mutation. So PIK3CA pathway is altered in various breast cancers, endometrial cancers, colon cancers, and lung cancers. So when it comes to PIK3CA mutation, there are various domains of mutation, but what is important and which are the hotspot is this helical domain, that is the exon 9 of PIK3CA gene, and tyrosine kinase domain, exon 20 of this gene. So more than 80% mutations are located in these exons. And if we see like the frequency of PIK3CA mutation in breast cancer, it is seen in about 20 to 30% of patients. And it is usually seen in these hotspots. So which are the breast cancers which will have these mutations? So highest frequency is seen in luminal A subtypes, which is followed by HER2 enriched tumors. Now, why is it important to test PIK3CA in breast cancer? So if we take like a case scenario of hormone positive, HER2 negative, and HER2 positive. So in early breast cancer, if we see if patient has PIK3CA mutation, the recurrence-free survival was better than those with wild type. But if you see a metastatic setting, PIK3CA mutation confers resistance to chemotherapy. So again, a prognostic importance. And if we see in HER2 positive tumor, it has a poor response to anti-HER2 treatment, and it is also a poor disease-free survival. So it is a poor prognostic. So coming to this predictive significance, the alpha selective PIK3 inhibitor alpelisib combined with fulvestrant in advanced breast cancer. This was approved by US FDA, especially in postmenopausal hormone receptor positive and HER2 negative breast cancer following progression on or after any endocrine based therapy. So considering the prognostic and the predictive implications, it is important that we test for PIK3CA in this advanced or metastatic breast cancers. So how do you test this PIK3CA? So now we have known that more than 80% are on these hotspots. So you can either take a hotspot gene real-time PCR, or you can do Sanger sequencing of exon 9 or exon 20, or you can do even as a part of NGS. So FDA has approved this TheraScreen PIK3CA RQ-PCR kit, but nevertheless you can use any other detection system. We are in our lab, we are using real-time PCR, and also we are doing NGS. So next gene which is important is BRCA testing, breast cancer antigen testing. So coming to the BRCA gene, so we know that it is not a specific like PIK3CA very hotspot. It is like a very heterogeneous, and the mutations are scattered throughout the gene. And not only the BRCA mutation, what is important is that genes which are in the BRCA binding regions like PALB2, RAD51C, RAD51D, all these genes are important and play an important role when it comes to BRCA testing. And it has huge clinical implications in breast as well as ovarian cancers. So what happens when the tumor is BRCA mutant? So it has a deficiency in homologous recombination. What does that mean? That the tumor cannot be now DNA. There is a DNA damage. There is a double stranded DNA break, and it cannot be repaired. So this leads to genomic scars. So whenever this is the scenario, they have increased response to PARP inhibitor. And PARP inhibitor olaparib have been approved as a therapeutic agent for such cases, and in both germline and somatic settings. So is mutation the only thing that we will look for? No, when it comes to BRCA, it is not just a single point mutation. You have different kind of gene rearrangement, you have amplification, you have promoter region methylation. So combined thing of this leads to homologous recombination deficiency and is called as BRCA-ness. But most of the testing that we see will say that BRCA mutations. So this was a paper in Nature Medicine on HR Detect, which showed that there was significant number of patients which were not showing mutation, but there was functional BRCA deficiency or homologous gene deficiency. So what does that mean? That the current testing was picking up to 5% of the testing, but when you combine everything like methylation, amplification, gene rearrangement, different other genes, the deficiency was seen up to 22%. That means these many patients can have selective therapeutic sensitivity to PARP inhibition, and with the current testing we might be missing these many percent of patients. So how do you test? So NGS is the preferred method, because in NGS it is not just DNA level, you can also see in gene rearrangement, RNA level, you can detect amplifications, everything in one go. So when you detect tumor tissue, it has both germline as well as somatic. When you detect tumor, it doesn't mean, or you cannot differentiate it from the germline testing. And one test to identify the deleterious variants. So whenever you get an NGS report, always see to it that what areas are covered. Is it just the mutation, or it is even covering the fusions, SNVs, amplification? If all exons are covered or not. Then also you should pay important, like what is the NGS workflow, whether it is both DNA, RNA based, and what are the potential sources of error. When it comes to potential sources, means what was the input tumor content. So what are the recommendations when you released BRCA reports? Is you have to check the suitability of the tumor sample. It is not a germline testing, it is a somatic testing. So what is the input tumor? What is the percentage of neoplastic content is important. Which are the target analyzed? Is it just BRCA gene, or is it any other genes that is also covered? Just the coding region or the introns or exonic regions? Overall result should be according to tier, like tier 1, tier 2, whether it is pathogenic, likely pathogenic, all the nomenclature according to HGBS nomenclature. And there is a category of VUS, that is variant of unknown significance. You just can't say it is BRCA mutation. You have to always categorize into which tier of reporting. So if it is tier 3, that it is just for record and you are not sure of what is the clinical or the biological significance of this variant. So all this should be, there should be comment about the particular variant that is detected. So as we saw, you can have a tumor BRCA testing, or you can have blood, that is the germline testing. So currently germline BRCA testing is very much validated, and there is a strong evidence of this germline to PARP inhibitor. Tumor is still being, like somatic testing is still being validated. Not every lab is doing the entire spectrum of BRCA-ness. We are also doing BRCA testing, but again, we are just doing the BRCA mutation testing, and rest of the alterations are in the pathway. So this is how a sample NGS report should be, like histological diagnosis. What is the methodology that is used? What is the histological diagnosis? Which are the different results according to the tier based? If it is also having amplification, then a comment of the particular alterations that you got. What is the depth of coverage? Then the details about the SNVs, which are the mutations, which are the genes where no mutation was detected, RNA alteration. So a combined thing of this should be in the gene. And as a physician or a medical oncologist, you should always see to it that just don't take any test as negative. Just see what panel and what methodology is used. So coming to the last part, that is the liquid biopsy. So when you look at liquid biopsy, what exactly is the liquid biopsy? What are the components of liquid biopsy? What impact, and most important, what are the challenges of analysis of the liquid biopsy? So what is liquid biopsy or liquid profiling? It refers to the analysis of any tumor derived material which is circulating in blood or any other body fluid. So it can be CSF, it can be in pleural effusion, ascitic fluid, urine, but which is the most widely used source is the peripheral blood. So it can be used as the alternative to surgical biopsy, and it is the very important and non-invasive method, and we will see in subsequent slides how it can be made use of in the clinical scenarios. So liquid biopsy, what all does it include? So it has circulating tumor cells, it has circulating tumor DNA, you have exosomes, ctRNA, and even tumor educated platelets. So in this talk, I will be mostly restricted into circulated tumor DNA, as most of the studies in clinical practice are on this circulating tumor DNA. So actually, when it comes to liquid profiling, it is like finding a needle in the haystack. It is like the amount of tumor fraction is very less, and you have to use very high sensitive technique, and you should have very high technical competency. So what are circulating tumor cells? It is the presence of intact tumor cells in the bloodstream. So how will you identify? So you have to take blood, then depending on the various techniques or platforms. So either people use like filtration technique where they will take 7.5 or 10 ml of blood, and there will be a sieve kind of like cell sieve is the technique, and they will filter. So it is assumed that tumor cells have a larger size than the blood cells, and they will get sticked onto the filter, and then this on this filter they put an antibody cocktail, and this is seen under the fluorescent microscope. So it is like among millions of cells, even a single cell CTC, if you find, it is of significance. Other things, they use an antibody cocktail and they do a magnetic separation of these cells, and then analysis is done. So there are various studies. Some use a cutoff as small as like 5 cells in 10 ml of blood, even that is of prognostic importance. So mostly CTC studies are done in metastatic breast cancer, prostate, colorectal cancers. So as I saw, very low number, and you need very high sensitive and specific techniques to isolate. So what is circulating tumor DNA? So circulating tumor DNA is from the primary tumor, metastatic tumor. So dead cells, they are circulating in the circulation. So what is very difficult about assessing circulating tumor DNA, that the fraction of tumor DNA is very low. And how sure you are that the DNA that you have extracted from the blood, from the plasma, belongs to the tumor, or it is from other non-tumor DNA. So that differentiation is very important. Other than that, it has a very shorter plasma half-life. So when you get a negative result, you are not sure that is it a true negative or a false negative. Also, the amount of ctDNA will depend on various factors like what is the location of the tumor, what is the tumor type, tumor size, tumor stage, tumor metastasis, what are the previous treatment that has been taken, if there is a CTC lysis. So all these factors play an important role. Nevertheless, we see that there is frequency of cases with detectable ctDNA increase with the increasing stage, irrespective of the tumor type, whether it is breast, colon, pancreas, colorectal. So what impact can a ctDNA can do? So if we see, ctDNA can be helpful in cancer detection, early diagnosis. You can extract ctDNA and do molecular profiling or prognostication. It is useful for detection of residual disease. And most importantly, when your patient is on treatment, it can helpful in monitoring the response or monitoring the clonal evaluation. So these are the 4 spectrums where ctDNA is important. So does that mean it can fully replace the tumor tissue biopsy? No, it cannot. Because now I will tell you what are the technical barriers when you analyze a liquid biopsy. So there are various technical pre-analytical issues. Also, the liquid profiling is associated with high specificity. That means when you get a positive, it's fine, it is positive. But when you get a negative, you are not sure whether it is true negative or. And there is a challenge when it comes to collecting plasma along with the tumor biopsies. So I will just explain the workflow. So what are the challenges from technical point of view to take into account if there is a sample? So there are some studies which are done on buffy coat, on plasma, serum. But what does the study say? The plasma, when you extract it from the plasma, it is most important. Then which tube to collect, whether you collect in plain tube or you collect in EDTA, there are preservative tubes. So most of the studies, they say that EDTA tubes are okay. But if you get that preservative tubes like Sprek or Roche, it is very good because it can preserve the ctDNA for a longer period of time. You are never supposed to freeze the blood before you collect plasma from it or extract ctDNA from it. Again, the centrifugation switch. So you get a blood sample, you separate it plasma and extract it within 2 hours if it is stored in EDTA. It is very important. Otherwise, what will happen? There will be lysis of WBC and there will be all wild type DNA in the blood. So again, the low fraction of tumor will get diluted with the wild type, and again there will be analysis error. Again, centrifugation, it should be high speed, double spin when you want to extract it. So these are the various technical nuances which you should know when you deal with liquid biopsies. Other than that, once you have isolated also, what techniques? You can't just say that liquid biopsy was negative. You should see whether it was Sanger sequencing, it was a real-time PCR, or whether it was ultra-sensitive cap sequencing or very ultra-sensitive deep, too much depth of the sequencing. So these are the various issues that you should keep in mind. So what is the important? Like it is high specific lower. So if you see like majority of the patients will have concordant tissue and plasma genotypic result. But this is the area where the tumor is positive on the tissue, but in the circulating tumor DNA, it is negative. So this is an area which we are worried and which we don't wish to miss. So what the guidelines say, if your liquid biopsy is negative, then you should definitely do a genomic testing on the solid tumor. So these were the technical aspects of liquid. So what is the role of this in management of breast cancer? So broadly, if you see like diagnosis and early stage of breast cancer, so there are various studies which says that plasma ctDNA, if you just extract ctDNA and you measure the concentration, you will see that as compared to the healthy controls, the concentration of plasma ctDNA is higher. That is how you can early detect the tumor presence. Again, if it is nodal metastasis, the greater amount of larger DNA fragments. So studies have also showed that even in early stage breast cancer, the ctDNA was like 100% concordant with the tissue testing, and the clinical utility is enhanced by identification of even actionable biomarker which were detected in the liquid biopsy but not seen in the tissue. So this is very important. So you can also see, because in blood you will have a heterogeneous population and different clones that you can cover rather than a single site biopsy. So if your tumor fraction is high, it is very well off and very important. Second, to assess the response and resistance to treatment. So if a particular case, like your patient is on the treatment, and if you want to see like how the patient is responding, so you can collect a ctDNA and just see what is the concentration of ctDNA. So what studies have shown that if patient is on a treatment and now if there are increased ctDNA levels, that and following the treatment shows disease progression. Or for example, if patient is HER2 positive on trastuzumab and resistant to trastuzumab, such patient, the ctDNA showed genetic alterations to TP53 and PIK3CA, which showed the resistance to HER2 target. Thirdly, for predicting the recurrence of the breast cancer. So studies have shown that the evidence of relapse, the ctDNA was able to detect the recurrence 7 months to 2 years prior to the clinical or radiological discovery. So to summarize, liquid biopsy is a promising biomarker and a non-invasive way of assessment, and it is a potential alternative to tissue biopsy. But when it is negative, you have to restrict to the tissue biopsy, and it provides a wealth of information relevant to determining the tumor status, potential of treatment response, and likelihood of relapse. So with this, I would like to end my talk. I would like to thank you all for patient listening. Thanks to the coordinators and organizers for inviting me to present this talk. And this is our molecular lab, and this is our core NGS reporting team. Thank you.
Thank you, Dr. Trupti. I think that was very lucid and very informative talk regarding all the molecular techniques. And I'm sure today a lot of people have learned a lot more important aspect, especially about liquid biopsy. So thank you for that wonderful talk.